So good afternoon, everyone. My sincere regards to our chairpersons and hello to all my colleagues. Today I am going to talk on a topic which is a little bit different. It is ART and fertility preservation in special conditions, breast cancer patients and post-renal transplant patients. We all know breast cancer statistics is going up. It has overtaken cervical cancer. And every fourth minute, we diagnose one patient of breast cancer. Every 13 minutes, we loses one patient due to breast cancer. And the incidence is going up because, and more younger population. We know 40% of our population in our country is less than 40 years. So younger women are also coming. And because of good education and career, they still haven't planned their family. So they need a good advice regarding fertility preservation. So I will be covering effect of cancer on fertility, effect of cancer treatment, counseling, little bit about BRCA gene, which protocol trigger, role of GnRH agonist therapy, precautions, and post-treatment embryo transfer, and risk of recurrence. So we all know the effect of cancer on fertility. Cancer is it's a state of increased catabolic state. Patient get a lot of nausea, vomiting, that leads to multiple deficiencies, and that affects our fertility. Secondly, increased stress hormone causes increased prolactin, endogenous opioids, altered defective hormonal secretions. This all leads to decreased ovarian reserve. And if the patient is BRCA1 genes positive, her ovarian reserve is found to be less. So cancer compromises ovarian response. If we see effect of cancer treatment, the risk of premature ovarian failure if the lady is more than 30 years is almost 100% if cyclophosphamide is used. It is 13% if patient is less than 20 years. So it means the effect of treatment is also bad on infertility. It depends upon age of patient, type of chemotherapic agent used, for how long it is used. But fortunately, in few patients, we may see spontaneous resumption of ovulation after chemotherapy. So these patients definitely need some kind of advice. And this is the drug list: low risk drugs, high risk drugs. So most important thing is to discuss with our treating oncologist about need for fertility preservation by use of less ovotoxic drugs, and their counseling also. Kindly refer patients to fertility doctors if patient is young. So regarding counseling, if this patient, they come to us for counseling, these families are very, very distressed. They're very scared. They're very scared of dying. So they may not understand the need for fertility preservation on first time, but we must tell them, it is a good idea. It is not going to affect cancer treatment. It is not going to affect recurrence and 5-year survival. Everything is very good. And after doing a good counseling, patient may agree for fertility preservation, and which we all should do. Now, a little bit about estrogen progesterone receptors. These are found in 2/3 of patients of breast cancers. And breast cancers, they are sensitive to estrogen. So we have to be very careful that which protocol we are using, because estrogen level may increase the growth of breast cancer. There are BRCA1 gene. These genes are found. If it is found, it causes low. These patients have low ovarian reserve. BRCA2 has got no bad effect on fertility, and these genes in 40 to 80% causes breast cancer. 10 to 15% cases they causes ovarian cancer. So many patients with family history of breast cancer, or those who are genes positive, they undergo mastectomy after planning pregnancy, or maybe before planning pregnancy, and they go for fertility preservation, and later they plan bilateral salpingo oophorectomy. So once the patient is counseling is done, and she knows that her fertility is compromised and she can plan later, she's coming to us for fertility preservation and stimulation. After talking to our oncologist, we take a proper consent, and protocol depends upon how much time we have between stimulation and chemotherapy. Besides this also depends upon age of patient, what grade she's having. Whether she's unmarried, then she'll go for oocyte freezing. She's married, then embryo preservation, and whether she's receptor positive, and whether she's BRCA gene positive. And ovarian reserve function test definitely needs to be done. So depending upon these all findings, we can use conventional or antagonist protocol, or luteal halt, or dual stimulation, or patient with positive receptor, we have to go for letrozole or tamoxifen protocols. So suppose the patient is coming in mid-cycle, then and time is very less, then we have to start random start protocol. In this, there are two protocols in which we give 3 milligrams higher dose of antagonist to break the costless luteum. We can wait for periods to come. Within 2 to 3 days, usually they come, and we can start stimulation. Or the Michelle Wolf said, don't wait for period, give antagonist and start with agonist. and cycle is started. This is a little bit about patient who are estrogen progesterone receptor positive. We all know aromatase inhibitors. Is it gone somewhere, my presentation? Oh my God.
It is visible, Sujata. We can see.
मेरी screen से कहाँ चला गया? एक second. We know letrozole is a third generation aromatase inhibitors. It converts androgen to estrogen. Half-life is 48 hours. And this protocol causes significantly low level of estrogen. And this is very, very useful in patients who are receptor positive. And the dose is 5 milligrams started from second, third day along with gonadotropin till the day of trigger. And once we give the trigger, we'll stop letrozole. After egg retrieval, again we can start letrozole for 5 days, then check estrogen levels. If they are less than 50, we can stop it. If more than 50, we can further continue for 3-4 days. And we know, but one thing we have to be very careful, that trigger should be given when the follicles are 20 millimeters, because there is a risk of getting immature oocytes in these patients with letrozole protocols, because low estrogen level in follicular fruit alters microenvironment and delayed expression of genes on cumulus required for ovulation. So always give trigger on 20 in patients with letrozole protocols. This is the study which is saying same thing. Now this is another publication, not very old, in 2013, on 2013 June. This says letrozole protocol along with gonadotropin is a good choice and it keeps estrogen level very less. This is another publication in 2020 in Human Reproduction, which also says, which compares letrozole stimulation, gonadotropin, and only letrozole. No letrozole. So they say oocyte retrieval are almost similar, mature oocytes are almost similar, and oocyte cryopreserved is also similar. Fertilization rate is also similar. So using letrozole is not going to have detrimental effect on oocyte quality. So letrozole protocol should be considered in patients who are receptor positive. Now, a little bit about dual stimulation. If we see this chart, we see rise in FSH, again rise in FSH, again rise in FSH. So this 3-time rise in FSH is responsible for 3 follicular waveform: first wave, second wave after LH surge, and third wave. And we can use this for our quick retrieval of good number of oocytes in patients who are poor responders when the time is less, and patient with BRCA gene mutation, BRCA gene 1 positive patients. So dual stimulation is a good idea in patient with poor ovarian response. Always use agonist trigger, because HC trigger can cause prolonged high rise of estrogen, which is not, we don't need that. Agonist trigger is also good because we can start chemotherapy after 48 hours. It is also good if we are planning in young patients who are PCOS, and if patient LH is endogenous LH is very less, patient is of poor response, low responder, then it is better to give a dual trigger. Now, precautions during ovum pickup, we have to be very careful, because these young girls, they have got low platelets. There can be risk of bleeding. So it's better to transfuse platelets before ovum pickup. Give them good antibiotics to prevent abscess formation, because sometimes they can have neutropenia also. And try to not to make any kind of hematoma in ovary, so that we can start quickly chemotherapy after 48 hours. Little bit about GnRH agonist administration. This is something new which is now everybody is using, and this therapy started 1 week before chemotherapy to avoid flare effect. And the idea behind starting this therapy is it mimics like pre-puberty stage, and we all know once the patient get pre-puberty stage, like hormones, there is no follicular growth, and chemotherapeutic agents, they attack mainly developing follicles. So this way we can save our follicles for destruction, but this cannot replace fertility preservation. And the other way of GnRH agonist is it is anti-apoptotic, and also it decreases utero-ovarian perfusion, so the less exposure of ovary to chemotherapy. So this is a good idea to prevent premature ovarian failure, and this is also a strong recommendation by ASHRAE guidelines. Now, after how long we can wait? So after 48 hours, we can do start chemotherapy. And after 1 year of post-chemotherapy, patient can plan for pregnancy after 1 year of completion of her chemotherapy. But clearance from oncologist is must. And this is also a strong recommendation. She can plan pregnancy after 1 year. And the patients, many times they come and say, is there is a chance of recurrence after treatment? So this is a publication which is going to come in October 24. And this also says performing ovarian stimulation ART following cancer treatment is not going to affect recurrence rate. Another publication in Human Reproduction also says it is safe to perform IVF after treatment for breast cancer, and this is the European journal also says it is safe. So by showing all these data, we can gain confidence of patient at the time of counseling, and they can go for fertility preservation. But it is seen that these oocytes which are collected in these cancer patients, they have got a poor survival rate post-thaw, maybe because of a direct effect of cancer or mental stress or other cytokine imbalance. But it has been seen that these oocytes are not as good as patients who are not having cancer of same age. The new techniques are, if the patient is very young or we have no time, so we can do ovarian tissue cryopreservation. This can be combined with chemotherapy also. This can be done along with surgery also. And 1 millimeter small cortical layers are made and they are slowly freezed. And this is a new technique. The other one is in vitro maturation. It has got only 50% maturation rate and it needs highly skilled embryologists and a very good lab. One word of caution, we must tell patients and oncologists that please don't use drugs who are cardiotoxic, because if these patients are planning to conceive, then later they may land up into reversible or permanent cardiac damage and cardiomyopathies, and this may cause problem during pregnancy. Now to conclude, so now we have done counseling, we have done everything, and patient is gone for fertility preservation with the agonist protocol. So this is the complete way to treat these patients. So to conclude, this incidence is going up breast cancer, and BRCA1 mutation positive patient has low ovarian reserve and they are less responsive to stimulation. Letrozole FSH protocol is a very good protocol because it gives low estrogen levels, and antagonist with agonist trigger is the preferred protocol we should use. GnRH agonist is a promising therapy to preserve natural fertility. Random start protocol also gives good quality of embryo, especially when the time is less. Chemotherapy can be started 48 hours after oocyte retrieval. Embryo transfer should be done after getting remission, 1 year post-remission, and written consent of oncologist. Oocyte quality is little compromised in these patients, and PGD can be done in BRCA1 positive patients, and risk of congenital anomalies are not increased in these patients. So this was about cancer patients. Just 5 more minutes for IVF in post-renal transplant. This is the transplanted kidney which is usually placed over iliac crest. So why we are getting more patients post-renal transplant these days? Because of diabetes, hypertension, obesity, lifestyle modification, pesticides, environmental toxins, autoimmune disorders. These all are affecting our younger population, and many of them sometimes land up into kidney failure and they have to undergo renal transplant. They also need fertility preservation. So once they come to us, they have lots of questions. They ask, ma'am, can I become pregnant after transplant? Is spontaneous pregnancy possible? Is pregnancy safe after transplant? How long should I wait? Do immunosuppressive medicine needs to be adjusted? Do these babies are at risk? Can I breastfeed? Can I have a normal delivery? As the babies are more going to have congenital anomalies. So there are so many questions and we must counsel them one by one. So yes, the patient asks, ma'am, can I conceive normally? Yes, you can conceive normally, but usually the fertility is reduced after renal transplant because chronic renal disease which was there causes uremic toxins which affects AMH. Secondary repeated dialysis also causes premature ovarian failure. These patients have sexual disorders also, and the coexisting renal disease can affect ovary also. So these patients are usually with low fertility and they need IVF and other kind of treatments. So is it ethical to advise these patients? They have only one kidney and they can land up into graft rejection. So this article says, yes, it is ethical, but we must tell them all the pros and cons and what things can happen later in great detail, everything in writing and with our nephrologist consent. And after how long they can conceive? They can conceive after 2 years of renal transplant. By the time the graft is very good, the all kidney functions, they have come back to normal, all deficiencies has been corrected. So 2 years post transplant they can conceive. This is said by American Association and both European Association. So what are the prerequisites? If patient is coming with 2 years post transplant, everything is fine, then graft function is good, consent is taken, then normal renal function should be there. Creatinine should be less than 1.5. Normal Doppler studies, graft should be good functioning with a lot of blood flow, BP should be corrected, proteinuria should not be there, and normal maintenance of immunosuppressive therapy should be there, and no teratogenic drug given in last 6 weeks. This needs to be done before, and we must know where is the kidney, because we should not damage kidney at the time of ovum pickup. Now, patient ask, are these pregnancies are high risk? Yes, these are, because there are more risk of preeclampsia, gestational diabetes, IUGR, preterm, sudden IOD, prematurity, everything. Patient can have a deteriorating renal function. She sometimes, rarely, she can have a graft rejection also. And there are more chances of LSCS, and she can have a refractory anemia because of chronic renal disease. So, and adjustment of the immunosuppressant drug is very important. Embryotoxic drug should be changed, and this is done by proper counseling with nephrologist. Now, is normal delivery possible? Yes, the kidney is quite high up. Normal delivery is possible, but LSCS is commonly done because of associated maternal and fetal conditions. So, LSCS is more common in these young girls. Now, breastfeeding, can they feed? Yes, they can feed, because drug is excreted in very, very less amount, and the benefit outweighs the risk. So patient can breastfeed. Now, what precaution we should take while doing IVF? We always do a minimum stimulation, because more stimulation can press this transplanted kidney and can cause damage to this kidney, damage to their blood flow. And we can use any protocol depending upon her parameters, what is her ovarian reserve and everything. Always give agonistic trigger, because we don't want hyperstimulation at any cost. All adjuvants can be given as required, because hyperstimulation can again can affect renal functions and graft rejection. And oocyte collection can be difficult because of presence of pelvic kidney, and sometimes we might need abdominal pickup in these patients. And ovum pickup may be difficult due to presence of adhesions also. And single embryo, always single embryo, because we all know multi-pregnancy has got all those side effects which these patients are already at risk. Now, this paper shows ovarian hyperstimulation, and it affects on renal function, and they say it should not be it should always be avoided, because ovarian enlargement secondary to hyperstimulation can obstruct transplant kidney, their blood flow, and can further deteriorate renal function. So counseling, yes, we have answered all these questions. You can conceive, you can have a normal delivery, you can we can do it. Your babies will be at risk, but tertiary care and in good hands, it will be safe, and you can breastfeed your babies. And thank you so much.
Thank you, Dr. Sujata. I think it was a wonderful talk, and you covered all the aspects very well. I will request our chairpersons, Dr. Sharma sir, Dr. Sharda Jain ma'am, and Dr. Shalini to give their comments.
Sharda ma'am.
Dr. Sharma first.
Okay.
Thank you, ma'am. Thank you. Thank you, Dr. Sujata, for such a wonderful, overview of the subjects and those, emerging subjects, I would say. Because as we all know that the breast cancer is increasing, and the renal transplants in the women also, it is increasing. And we as an infertility specialist, we have to now gear up, to cater for this type of population. And the protocols and all which you mentioned now, that also we should be very conversant with them, and so that we can shorten the stimulation, shorten the estrogen level, and take out the eggs in time, so that the side effects of estrogen on the breast cancer and all is not there. Now the question is that how many oocytes would be sufficient, because we have to counsel the patients, because the number of oocytes, how many will be freezing them, to give them a pregnancy, because we all know that the pregnancy can never be 100%. So that part of counseling we have to give to them, that for how many oocytes, whether we should, because we can't be stimulating them again and again to get more eggs. So it has to be maybe only the one stimulation only, or maximum is the dual stimulation which you can do to them, nothing more than that.
आपका patient तो नहीं है डॉक्टर?
And preferably, if the husband is there, then better to freeze the embryos rather than to freeze the oocytes for these patients. Another question was that whether we should allow them breastfeeding, especially the breast cancer patients. or it's all totally no-no for them. How long we can keep these oocytes? I had a case where she had a rectal carcinoma, and for that she preserved her oocytes. And now she has gone to New Zealand, and we have no contact, and we don't know what to do with her oocytes. So I think now, as per the government, 5 years is the maximum we can keep it, or maybe 10 years in the case of malignancy. But beyond that, there has to be a limit. When if the patient doesn't come, then how do we dispose of those oocytes? So, about the breastfeeding, what is your opinion in the cases of CA breast? She becomes pregnant by oocytes or spontaneously later on.
I think she can breastfeed.
Yes, breastfeed is not contraindicated in
Absolutely.
CA
Once
breast
the
patients.
remission is there and she's
Yeah.
cancer free for 1 year, she can breastfeed.
And in a renal transplant patient,
Yeah, the benefit is
immunosuppressant up even after that.
yeah, the amount of immunosuppressant drugs are very, very less. So the effect of breastfeeding is more than not feeding the baby. So they can feed. But yeah.
I think what Dr. Sujata, you have really opened up a new area, and time has come that all infertility experts should know about the facts, and because they have to counsel. And still, we find that at this particular time, both the family and the patient are stressed, and they don't want to talk about fertility preservation. But I'm sure the barriers are breaking up. Very clearly, you have said that because the time at our disposal is very little, we must be very strict, and we must know the protocols very clearly. So there is no confusion among the two infertility surgeons as far things are concerned. There should be a standardized protocol. And you already said that if the people who have a family history of breast cancer, it's a BRCA1 which is responsible for low ovarian reserve, and it is not the BRCA2 which is affects the things. I'm glad to know that the Dr. Brigadier Sharma has opened up a question: how many embryos you need to preserve, and in case a patient happens to be unmarried, that how many eggs need to be preserved. I feel because this it is only one cycle they can do it, so it is more than 10, 12 eggs or embryos you will not be able to save, even if you use a dual stimulation in such patients. I'm also glad to know that I did not know about it, that it is such a short period that you finish a chemotherapy and after 1 year she can be allowed to have pregnancy. I think that's it was a news to me. And because after bariatric surgery also we say that minimum 1 to 1.5 year you must definitely give a gap, and not earlier than that. So after this particular surgery, if she's keen for it, then I think you said it is 1 year. I think it's absolutely great. As for the renal transplant cases are there, I have my own reservation, because the kidneys are very precious in such particular patient, whether they should take an insult of pregnancy or not. Uh, I think, for me, I was keen to listen to you, but you gave a very rosy picture, provided the patient is counseled in detail. She knows everything about her condition, and in spite of that she wants to go for pregnancy. Then you have said that there are no inhibitions as far the pregnancy is concerned. uh, uh, I thought, I have reservations, but I think you opened my things for clarification. So at least I am now open to it. Not that open, but yes, open to things. uh, I think you very rightly said ethical issues. Whether breast cancer is getting cancer, so there are no ethical issues involved. Fertility preservation must be done, but I think no ethical issues are involved. Even if in renal transplant cases, also they can go ahead with pregnancy. So I will definitely say, Sujata, it was wonderful. Eye-opener session for me to get few informations out of this particular presentation. Thank you very much.
Thank you so much, ma'am. Thank you, sir. So 10 to 12 oocytes we should preserve. They can breastfeed, and a very good counseling, everything in return. Side effects of pregnancy, side effects of IVF, and risk of graft rejection should be very, very clearly highlighted in the comments before starting any kind of treatment in post-renal transplant patients. Shalini?
Yes, yes, ma'am. So Dr. Sujata has given a very good overview of the CA breast and even the renal transplant patients. The only thing, I was just reading one article yesterday itself only, that whether pregnancy increases the risk of CA breast or not. If the patient is already CA breast, has taken the treatment, then once she becomes pregnant, so the outcome was, and the conclusion was that the pregnancy does not increase the risk, further risk of CA breast. And I think it's clear now that these patients can also breastfeed. And regarding, certainly, it is a multidisciplinary approach. We see these days we are seeing a surge in rise in these number of patients. Patients are becoming aware. The oncologists, they are becoming aware. In, like especially working in corporate hospitals, they do send us a lot of patients now for the fertility preservation. Definitely, race is against the time. Protocols, Sujata has very clearly highlighted. And I feel about the renal transplant also, Sujata has given us the picture. We, as the fertility specialist, we have to give them a very true picture. As Sujata also said, sir also said, and ma'am also said, that definitely the quality of eggs in these patients, certainly we find, is low and is not that as great as we compare to the those patients, those who don't have the cancer. So a very detailed counseling, we should be doing it. And I think the patient, obviously the protocols and all, it is the random start protocols that we don't need to go in detail right now. But as such, it's a multidisciplinary and a very detailed counseling that we need to do with the patient, and especially the medical legal aspects, and especially the issues come when the partner dies. Should we be giving the eggs or the eggs preserved to the parents, or if the embryos are preserved, should we be giving to the partner and all? So there are a lot of couple of gray areas that itself is again a very again a detailed talk. We can take another topic on that. But then all these points have to be, these patients have to be counseled, considering the 5 year survival rate. And it is not like that all the patients are coming to us. Suppose the patient is already at a stage of stage 3 and stage 4. So we need to counsel them on the prognosis, on the survival, and on the based on their, what is their survival and what is the chance of the oocyte preservation. Suppose the AMH is very, very low, then is there a point in preserving those eggs or not? So I think we need a multidisciplinary approach involving a psychologist, oncologist, fertility specialist, physician, and all these factors.
Good.
Yes, ma'am.